Good evening, everybody. I hope you all are doing good. So welcome to the Research and Publications webinar from I'm Ahmedabad. Today we're excited to host Professor Anand Nair from Michigan State University. So let me tell you brief about Anand. Anand is Eli Broad endowed professor in the Department of Supply Chain Management at Michigan State University. He obtained his PhD from the same place, and he had stints as a faculty in the University of South Carolina and Auburn University before he joined Michigan State. He works extensively in the areas of manufacturing, healthcare, and retail sectors on issues such as inventory management, forecasting, pricing, capacity planning, lean systems. In sum, Anand is quite adept in the area of operational excellence as such. His research examines in particular how firms and teams and individuals learn, adapt, and organize to manage processes, supplies, technology, and innovation, and the associated performance implications. Dr. Nair also sits on editorial boards of top journals such as Journal of Operations Management, and he had several awards, including the Fulbright Aalto University Distinguished Chair in 2017-18. He has several other associations in top organizations, and he's active in the AI and data science space as well. So without much delay, I'll give the floor to Anand, where his topic will be all about cost implications of consignment inventory management for general and physician preference items in healthcare. So again, this webinar will last for an hour. So if you have questions, please drop them in the chat box. I will keep an eye on them, and we will engage with you on a continuous basis. So I'll give the floor to Anand. It's all yours, Anand. So thank you so much.
Well, thank you, Devjit, for that nice introduction. Hello, everyone. Good morning from here and good evening over there. So thank you for inviting me for this invited talk on cost implications of consignment inventory management, a topic that we are currently working on. It's a joint work which also includes my co-authors, Claudia Rosales, who used to be at Michigan State University. Now she's at University of Arkansas. And Sukrit Pal, who is a doctoral student who will be graduating this year and joining Iowa State University as an assistant professor. So this research is a joint work, and we are excited about it. We find some interesting outcomes here, and given the audience that I am told I have here, I'm sure you might find this to be of value. I don't know how Indian context works, but that'll be a good discussion we can have. So feel free to ask questions if you have any time, and we can engage in a discussion so we can make it more like a conversation, as in the experiences we have here and what your situations at your hospitals and your work areas are. So here's the agenda that I will be following. I'll start with the research motivation. Why do we look at this particular issue? What made us think about it? I'll follow that up with a literature review, a very brief review of the scope of research that has happened here and what we are tapping into, how we are going to use some of that literature to build on our study. After that, I will present the empirical investigation. How did we follow that up with an empirical investigation, and the insights we got from the empirical study. Now, this is an empirically grounded analytical study. So we have both empirical analysis and analytical investigation. So after the empirical insights, I will emphasize what the analytical investigation we pursued after that and what the insights we got from that analytical investigation. And then I'll conclude this with some implications, just a recap of some of them, and in general, what we think healthcare organizations can think about from what we found in our study. All right, so starting with the research motivation, one of the things which is important to recognize, at least in US, this is the case, that the cost of healthcare is pretty high. And after labor, the materials related cost is the second most dominant cost factor in healthcare. So medical devices, materials, accounting, these are the costs that typically run as high as 30% of hospitals' operating budget. which means that these need to be carefully managed so that we can reduce cost. We can find ways in which management of different types of inventories can be handled, how we contract about these particular products, can we change some of those conditions. So those are sort of the starting motivation of cost reduction, finding ways by which hospitals can do so. Now, in healthcare, the supplies are quite distinct in terms of the way supplies are purchased. So you have general medical supplies. These would be your syringes, your scissors, your band-aids, and all those things. And then you will have physician preference items. These are the implants, pacemakers, some of those where physicians have very strong preference for choosing a certain product over the other. And this could be influenced because of their training. It could be influenced because of their interactions with companies and how these sales representative might have presented that particular item. And they found that this item actually works best for them. So there are items like that, which we call physician preference items. So we will be using these abbreviations GEN and PP to designate general medical supplies and physician preference items. When we think about organizations, the physician preference items are the ones where there is a disconnect between how materials management people actually can manage it, because they don't necessarily have too much of a say in terms of setting up the contracts for these, because these are finally physician preference items. So a surgeon might want a certain item, and that is what they want. So from the materials management point of view, they have to get it, right? So they do have to get that product, which means that there will be quite a variety that hospitals will be carrying. Physician preference items would have several types of the same kind of a product, which does exactly the same thing. But just because there are brand preferences, make preferences, you would have several of them within the hospital. So that's the nature of that. Therefore, demand variability is pretty high there. Whenever surgeons believe that they want to change it, they can. And typically the demand for physician preference item, at least the average demand, is relatively lower than general medical supplies. General medical supplies, you would need it in large volumes. So there is a distinct nature to their demand in the way they operate and the way they are actually selected. Now, because the costs are pretty high and because of this nature of demand, hospitals have been thinking about ways by which they can reduce the cost. And one of the way by which they do so is by using consignment inventory management, consignment stock. Now, what is a consignment agreement? It's consignment stock agreement essentially relates to a situation where a vendor would use the hospital's premises to store the inventory. The vendor still retains ownership of that until the hospital uses it. And once the hospital uses it, then hospital pays for that particular inventory in a one or 2 months time period. So there is something to gain for the hospital from the cost point of view, which is that they don't have to spend on the cost of capital until it is used. Number two, they actually don't have to worry about the replenishment policy that they'll have to follow. They don't have to closely monitor this product because the assumption is that the vendor would have done that for them, because that's what the vendor is going to do. Now, from the vendor's point of view, the advantage is that they actually can set up a contract where either they can ask for a higher price for these products because they're going to do some more administrative tasks here as compared to what they would have done otherwise. They are now going to manage the inventory of this product, or they can ask for higher volume. Because that can increase their revenue. So there is some mechanism that the vendor would want for this consignment stock agreement to work for them. So there is a common ground that both of them have to find when such an agreement will be established. And that is something which happens in healthcare organizations. And the objective is to reduce cost from the point of view of hospital. And from the point of view of a vendor, it is to be able to have that sustained revenue stream or increased revenue stream that they can get. So this is what the context is where we are studying a particular problem here. And within this context, we are utilizing some theoretical precepts from agency theory. So in our research, we want to build on some theoretical foundation, which helps us understand what are the underlying mechanics at work. What could be happening from the hospital's point of view, and what could be happening from the vendor's point of view. So it's a typical principal agent problem where the principal is the hospital, the agent is the vendor. And we want to build our study around this theoretical idea, around this principal agent problem. So we will take a look at how we try to structure it around it. Okay. Now, to study this problem, we interacted with a hospital. It's a large teaching and research hospital located in Midwestern United States. Right? So this is a organizational engagement that we have. It's a level 2 trauma center with over 600 beds, and on average, there's a spending of about $17 million in medical supplies. So with this particular hospital as our partner, we were interested in understanding how hospitals can reduce their cost by understanding how consignment inventory is working for them, and then thinking about what are the ways by which they can make it better by structuring a certain contract which actually can help them. So there are 2 research questions that we are answering in this study. The first one is, what is the effect of consignment stock on the cost of managing physician preference and general items? So that's like a question of, are we getting the benefit from consignment inventory in terms of reduction of costs for these types of products? That's what we are studying with the empirical part of our study. That is what the empirical investigation is, using data from this hospital. And then the second question we are analyzing is, what is the effect of using different consignment contracts to manage physician preference and general items? So here we want to understand, so if we find something from the empirical investigation, are there opportunities for the hospital and the vendor to come up with an agreement which actually can work for both parties? So what would be those kinds of structures be? And that's what we are studying with the analytical part of our study. So we are combining the 2. Now, I would not belabor with a lot of literature review, because I am sure many of you who are in the research stream, you must have looked at it, or you can always go back and take a look at it. But the literature spans few fields because our study is on consignment inventory. So we have to understand what has been written about consignment stock and its value. And most of these studies that focus on consignment inventories have been in the manufacturing and retail environment. That's where majority of the study has been. And a sample of some of the papers are listed. There are so many of them. So it's a huge literature base. So we observe that there is a stream of research which has been looking at consignment inventories. And majority of them have been looking in a for-profit kind of a context in a manufacturing retail, where there is inventory management to be done so that you can eventually sell it. And that's something which you always keep track of, how many inventories you made and how you sell it, or how many you bought and how you sold it. Now, the application of consignment inventory in healthcare setting is relatively lesser and has been looked at by few studies listed here. And in healthcare setting, obviously, it's a slightly different context. You don't have products that you're actually selling. It's not the inventory that you're trying to eventually sell. The objective of inventory is to provide patient care. So its objective is to make sure that you have the right quantities in stock. And that's very important, because you never want to be out of stock, but you're not going to eventually sell it. So you are tracking it more from the point of view of its usage for patient care. Now, if I look at this stream of research, majority of the studies have emphasized the advantages of consignment stock. It's got the benefit of reducing overall expenses for both the retailer and the distributor, whatever the context might be, vendor and hospital. Very few studies have looked at potential disadvantages. What could be potential disadvantage in such a setting? Now, these are some studies that have examined that. And the type of disadvantage that have been emphasized is that now when consignment inventory is put in place, we know that the vendor is responsible for ensuring that the inventories are restocked as needed. And they won't get paid until it's been used or sold by the principal, in this case, in a hospital. So in such situations, the tendency of the company that has bought inventory or got inventory, as in this case, hospital, to administer those inventories become relatively lower. The oversight that they will be putting on these inventories, because they assume that it's going to be managed by the vendor, is going to be relatively lower than had that inventory been managed by themselves in stock. Right? If there are inventories that they also manage themselves, compared to that, they would be managing these with relatively less oversight. Now, when that happens, there are certain costs that can happen. For instance, shrinkage is one of the big area which has been mentioned, that in such inventories, you observe a substantial amount of shrinkage, which could be in the form of obsolescence. It could be in the form of damage, theft. Now, anything of that kind, if it happens, the hospital or the retailer is responsible for it. Right? So from the hospital and retailer's point of view, they should be cognizant about it. They should be really taking care of their inventories, at least to the extent that they don't run into heavy cost on those front. But the reality is that because of the behavioral aspects involved, in general, managers would have a lesser of a tendency to really track such inventories to the extent they would otherwise. So those are things which motivates us to consider the idea that, okay, so there is a certain behavioral pattern, which means that these consignment inventory is more of a behavior-based contract, a behavior-based agreement between the principal and agent. An outcome of that particular agreement is not necessarily the forefront in that engagement. We don't necessarily look at what kind of costs actually are happening in the consignment inventory, because there are a lot of assumptions going on here. So that's one thing which we understood from the literature that we need to examine a little bit. The second thing we observed in the literature is that product types and looking at different types of products is relatively less in the literature. And in healthcare, as we just saw, general supplies, physician preference supplies are quite different from each other. And therefore, consideration of these product types are very important when we are thinking about the type of contract we would have, the type of inventories we should keep. That consideration is relatively less, and it's missing, and that needs to be brought in because these products are managed differently, they behave differently, and hence the cost implications are quite different. So we observe these factors, and therefore we think our contribution will be in terms of understanding how these agreements actually fare in healthcare setting and how these different types of products could be playing some role in that effect. Right? So that's the way we realize our study's contribution to the literature. And as I mentioned earlier, agency theory precepts is what we will be using for developing our ideas. Now, just to recap, I'm using the source here, a study which has already done it, and it's nicely presented in a figure. So I'm just going to use their framework here. Now, in this one, as you can see on the left-hand side, you have a behavior-based contract. On the right-hand side, you have outcome-based contract. And there could be a preference towards going one way or the other. Now, the consignment agreement is the behavior-based contract, like I mentioned earlier. And there are some underlying assumptions that have to hold for that agreement to work very well, which means that the principal and agent should have very low goal conflict, which means that in this case, hospital setting, vendor and the hospital should have less of a goal conflict, then this contract would work. The agent's risk aversion relative to principal is very high. Vendor's risk aversion relative to the hospital is high. If that happens, this contract would be the kind of contract you would go for. There's a difficulty in measuring outcome. in this case, it's relatively difficult, as I just mentioned, given the factor that you're not really tracking them. It's relatively difficult. So that's the way the contracts are. Outcome uncertainties are high here, and cost of information gathering and information asymmetry is supposed to be low. This is one assumption that we are really honing on, which is it really true that the cost of information gathering and information asymmetry is relatively low in healthcare setting when they are going for a consignment stock-based agreement? Now, hospitals have their own systems, technology, information system that help them track how inventories are at this point in time and what they need to do about this inventory. Now, incidentally, most of that tracking is for inventories that hospitals are managing themselves, right? So that they're tracking all the inventory that is out there in their warehouse, so that they ensure that the inventories are never out of stock and they are having the right amount of inventory. So there is information gathering happening for that. And we already know that the consignment is something which is managed by the vendor. So this is by definition not part of that accounting system. In the system, they don't have these inventories in place to actually look at what exactly is going on with these inventories. And whenever there's a periodic review that happens, that's the time when hospitals get to see what's going on with that inventory. So there is a certain period after which they go back and look at what the status of inventories are. At that point in time, they realize, okay, we've used this much, we have been keeping these many, there are quite a few obsolescence factors we have to take into consideration. Some of them got damaged. So there is this time duration between when they got the inventory and when they're going to actually track that consignment stock, which creates an information asymmetry between what the hospital thinks they have versus what actually they have. The vendor, on the other hand, is stocking it more from their risk aversion point of view, because they never want to be out of stock, because in the clause, typically in these contracts, going out of stock is going to cost them quite a bit of penalty. So from the vendor's point of view, there is an incentive for them to make sure that they have the right amount of inventory at the hospital. Now, these combination of conditions actually can create challenges in terms of the amount of these consignment stock we might be carrying in the hospital and how that cost might end up looking. So this is where we are really focusing on. That is the tendency of the agent to be risk averse and therefore having the right amount of stock, and the tendency of the hospital to not have the information because there's an information asymmetry here, right? So this motivated us to think a little bit about potentially what could be happening, and specifically given that we have two different types of products, general medical supplies and physician preference items. All right, so at this point, I'd pause a little bit to see if anybody has any questions or any clarifications.
I don't see any in the chat, but if you have a question, you can unmute and speak maybe.
All right, hearing no questions at this point, I'll move on to describing our empirical investigation, how we went about studying this problem. As I mentioned, we are working with our hospital partner for this study, and we collected data from their system for the top 3,000 items between a certain duration, January 2008 until July 2013. And these items were distinguished between general supplies and physician preference items. So we have this being categorized into whether it's a general medical supply or physician preference item. And we also know whether this particular item was managed as consignment stock or was it managed in-house. So we have that understanding also. So we have data on their average cost per unit. We have the number of units used per month for a particular supply. We also have information about the contract length associated with the item between the vendor and the hospital, how long in number of days, the price charged by the vendor based on standard unit of measure for an item, dummy variable that we now consider because we know there are certain items that are managed by group purchasing organization. Now in US, group purchasing organizations are sort of these companies that work with several hospitals to consolidate the purchase across these health systems. And by doing so, their value add is being able to negotiate a price which actually might be lower than if these hospital systems would have directly gone and negotiated with a vendor, a manufacturer or a distributor, right? So these group purchasing organizations play an important role in healthcare. So there are some of these supplies that are managed by group purchasing organizations and others are not. We also have captured the dummy variable for the time, because given a month, seasonality factors or the year may be different from other years, some other changes they might have made during those years. We have also looked at this time as an important dummy variable to be controlled for. So we use that as another control factor, with the January 2008 representing the base time. It's a month year combination. So January 2008. All right, so now from those items that we have collected data on, we considered those items for which we have at least 23 months of observation over the 2008 to 2013 time period. And this 23 months is because essentially you can have four possibilities: physician preference items that are managed as consignment, physician preference items that are managed in-house, general supplies that are managed as consignment, and general supplies that are managed in-house. So we wanted to see the minimum amount of time among these four categories for which we have data. Right? So we want to make sure that we have at least that much of data to analyze something. And that minimum number of months turns out to be about 23 months of observation. So we wanted to, out of those 3,000 items, we wanted to take those items for which at least we have those many months of supplies for those items. We removed the missing values for some of the variables, and then we have these many general supplies, 397 general supplies over a period of at least 23 months, and 217 physician preference items, again, over a period of at least 23 months. And so it could be more than that. So in total, the data has more than 30,000 observations. It's a panel data. And this is the structure of our empirical analysis. So it's a panel regression, random effects. We are trying to estimate how cost is associated with consignment, which is a dummy. Some variables, some items are consignment and others are not. Vendor price is a control variable because there could be that effect happening. So we want to ensure that vendor price is controlled for whether the item is managed by GPO or the hospital themselves. GPO stands for Group Purchasing Organizations. What's the contract length for the supply? And the month year, which is, as I said, the time which we want to control. And so this is our estimation model for this particular study. Now, as part of the empirical investigation, we are now looking at the summary statistic for this particular data. So for the entire data set, which includes physician preference items and general items, this provides the averages and standard deviations of cost. So on average, $2,636 with a standard deviation, which is quite a bit. That's the cost that they're incurring on a per month basis, monthly cost. The vendor price is about $148 average for the entire data set, and 46 is the standard deviation. Contract length in days, 1,822 days is the contract length on average, with a standard deviation which is noted here. And then about 18.73% of their products are under consignment in total, and then on average. And then GPO, 76% of these supplies are managed by group purchasing organizations. Now, if we were to segregate them into physician preference items and general items, you can see that the physician preference items are more expensive, 3,687 on average versus 1,768, which is expected because these are typically ortho implants, pacemakers. These are mostly very specialized products where physicians have strong preferences, whereas general supplies are the regular medical supplies, so they are not necessarily as expensive. Vendor price, cost-wise and vendor price, you can see the difference is quite substantial from the vendor price point of view. And the contract length, not too much of a difference, relatively similar. More number of items are under consignment for the physician preference items, about 34%, compared to general items, only 6%, right? So we see that there's a lot more tendency among hospitals, at least this hospital, for keeping physician preference items as a consignment stock agreement. And then these are the GPO percentage, the percentage of items that are managed by the group purchasing organization. This is the correlation table, essentially just to understand what's going on with these variables. We observe that the cost variable, which is number one, is positively, in the case of physician preference items, is positively correlated with the length of time that you have a contract, whether it's a GPO managed contract or not, vendor price, as well as whether it's a consignment or not. So consignment, clearly, we are seeing, at least correlation-wise, that those items which were under consignment are positively correlated. I mean, correlation doesn't mean that they are necessarily associated, but it's just that we do find that. We find that contract length is negatively correlated with consignment, which means that those items that are under consignment typically have lesser of a contract length. And they are also negatively correlated with the vendor price. So more the vendor price, the vendor contract length tendency is lesser. That's what happens in physician preference items, and this is what general items are. There are some variations, as you can see here, actually the consignment is negatively correlated with cost, and a few other changes that you can see that are out here. So quite easy to reflect on it. But the actual investigation that we do here is a panel regression. So this is our result from the panel regression analysis with the dependent variable being natural log of the cost for physician preference items and general items done separately. And the variables that I mentioned earlier, where our main variable of interest is consignment, all the others are control variables. And month year, we have several of these dummies, so we have omitted them for brevity. We don't put every single time dummies here, but there are several of these time dummies that we consider. So we can observe here that the consignment dummy is significantly associated with the cost in the case of physician preference items, increases the cost in the case of physician preference items, but is not significant in the case of general supplies. So this provides us sort of beyond the correlation, some further understanding after controlling for all these other factors, that those items that are under consignment actually have higher monthly cost for the hospital for physician preference items. Now that we try to look for the robustness of this result by doing some more analysis of the data. We split the data into high-priced physician preference items, because physician preference items is where we found that relationship. So we took that data and divided that into the price of the product, low versus high, and quantity that you purchase, low versus high, to see if there is some systematic difference in terms of the effect of consignment on the cost, depending on the price of the product or the quantities purchased. So except for the low price items, we see high price items, there is higher cost when you have a consignment inventory for PP items. But quantity wise, we notice that it's significant in both cases, high or low quantity, does not matter. Right, so that's one robustness. The other robustness we did was the idea that typically what you would expect is that the average cost of an item that you purchase from a vendor would typically be lower than the standard sticker price that the vendor provides, because you would negotiate and you would try to find volume discounts. So there will be that volume discount component. So what you would expect is that the actual cost per item on average should be lower than the sticker price that the vendor would be providing after considering discounts. But what so happens is that in the system, there are several items for which the average cost is higher than the standard price as well. Now, what are the conditions when this can happen? Average cost per item will be a function of whatever the sticker price is, minus any discount that the vendor might give, but plus any shrinkage cost that could happen, right? So because there's that extra cost of something which got damaged, which is now accounted for, paid for, and therefore it increases the average cost, or something which got stolen. or it got obsolete, the hospital has to take care of those costs. So there are also instances where the average cost can be higher than the standard price. So we wanted to see if there is this difference between the way consignment inventory impacts cost, depending on whether the average cost is higher than the standard price, sticker price provided by the vendor, or if the average cost is lower than the sticker price provided by the vendor. Higher would be the situation when there's a shrinkage involved. So we would expect that whenever the average cost is greater than sticker price, there should be a significant effect of consignment on that particular subset. So I'm not showing that here, but we did that. I have results of that as well. So that particular segment is where we find there's a significant effect, not for the one for which average cost was less than the standard price. So we noticed that shrinkage is getting captured because typically hospitals don't collect data on shrinkage. We already know that they don't administer them, so they don't really track how much of shrinkage cost, but it gets sort of subsumed in their average cost estimations. So we wanted to extract that component of the cost by doing this analysis. And that's another robustness check that we have, and few other robustness checks that we do to just ensure that this result, what we are observing, has some meaning here. So these are some empirical insights we get from our empirical investigation. We do notice that vendors are typically risk averse, so there would be more a tendency to keep the inventory at the hospital, and hospitals are clearly lacking information on the status of their existing consignment stock. Clearly there are situations where you have the average cost greater than standard price, and those are the ones in which consignment is actually negatively affecting or actually increasing the cost. We also talk to the managers just to get a sense of what they think typically the average shrinkage rates are. On average, about 10% higher for consignment stock-based items compared to the in-house inventory managed items. So hospital management believes that there is typically higher shrinkage that happens in these consignment stock-based agreements. Hospitals are paying for all units consumed, whether or not they were used for patient care, which means that even if it got lost or got obsolete, damaged, it's assumed to be it was consumed. It was not actually used for patient care, but they have to pay for it. So that's another factor we understood after this empirical investigation. And all costs associated with purchasing items from vendors were included in the same cost accounting. So we had to do this robustness check and extraction of the shrinkage cost by some clever means that I just mentioned earlier, right? So that's the way we were extracting the insights, and that's what we got from the empirical part of our study. So again, I'll pause to see if any questions at this point.
I think there are several physicians here. So if you want to compare, contrast with your strategies, we can have some discussion here.
All right, I know that's Thursday evening, 6 o'clock or 7 o'clock over there, so the energy levels might be lower. But yeah, if you come up with any other questions or any clarifications, do feel free to chip in as we speak, so don't have to wait till the end. So I will be, if there's no question, I'll move on to our analytical part of the study, right? So the analytical investigation supplements what we did in the empirical part of the study. Now, remember that the objective of our analytical investigation is to understand what type of contract actually can help if such situations like this is going on. So we developed some mathematical models using inventory management theory and use two types of inventory management policies, right? So I'm not aware of how much you're familiar with inventory management policies. My assumption is that you have gone through some of those in your curriculum. So you have this continuous review policy or periodic review policy, where perpetual inventory, what we call continuous review policy, which means that you're continuously tracking inventory, which happens in organizations. And then par level inventory is the term that we use in healthcare for a periodic review policy, where you don't continuously review the inventory, you review them at a certain period of time after every frequency that you've decided, every month or every few days, whatever that might be. So we look at these two types of scenarios of inventory management policies and develop some mathematical models for hospitals that are using consignment inventory to understand what the cost implications could be. All right, so we study two types of contracts because our discussion with the healthcare organization indicated that whenever a consignment inventory agreement has to be established with the vendor, typically there are two parameters that come into play. One is that the vendor would ask for higher per unit price because they want to cover their cost associated with managing consignment stock, because they have to now ensure that they are replenishing it at a certain frequency. They have to administer the quantities located at the hospital site. So they would want that to be covered by means of the price, or they would want a higher purchase volume because that would then help them increase the revenue, which I already mentioned earlier. So we consider these two types of contracts that are typically used for contracting for consignments. And we also analyze the two types of products, general supplies and physician preference items, based on their underlying characteristics. General supplies, typically the average demand is high, but their standard deviation of demand is low. We saw that also in the summary statistic. Physician preference items, typically the average demand is low, but the standard deviations are very high. You won't be buying them in large quantities, but they are expensive, and cost-wise, physician preference items are more expensive. So demand uncertainty high, demand uncertainty low, demand high in general supplies, demand low in physician preference items. So that's something which we need to keep in mind. That's sort of underlying idea that we have here. So and I'm not going to go into all the math that we have. I'm just going to present it at the level of our basic equation, which a lot of you are familiar with, of the higher per unit price contract. We go through all the development of our lemmas and all to find certain parameters that actually will work. But the total expected annual cost of in-house inventory for the hospital, the total cost, will be a sum of several components. You'll have the ordering cost, you will have the holding cost, and then you'll have any penalty cost and material cost, right? So this is a general understanding of it. But the key here is that the holding cost includes the cost of capital when you are managing it in-house. When the hospital is managing it in-house, they also manage the capital involved because they're already spending for it, and now they have to manage that holding the inventory, including the cost of capital. In contrast, when we are looking at the consignment inventory, that cost of capital is absent, right? And this quantity Q in-house versus Q consignment is different. So we have certain differences between the two. You don't have the shortage and penalty cost because now this is part of the vendor's responsibility, right? The vendor is going to manage it. So we are having these two basic equations, and that is what we are going to analyze to determine few things. When we analyze all this through several rounds of analytical investigation, we come up with, I see a chat question here. Out of curiosity, were the variables chosen didn't suffer from multicollinearity? Yeah, so for multicollinearity, yeah, vendor price and contract length should have a strong so we saw the correlation matrix before, and we saw that they are correlated. I mean, but they're not so highly correlated that we are reaching 0.8 and 0.9. They were around 0.23, 0.3 or something like that. So it's not very high correlation. And for multicollinearity, we did control for that using robust standard errors and all those things. So that helps us address some of the multicollinearity issues involved with the estimation method. So we do take care of that in our empirical investigation by ensuring that we have used the right model there. Yeah, good question. Okay, so now with that model that we just talked about in the previous slide, we come up with the maximum rate of increase in per unit price, because this is a higher per unit price contract, which means the hospital is willing to provide a vendor a certain product to be managed as consignment, which used to be managed in-house. So they are shifting from in-house to consignment. That shift would involve increase in the unit price, and that unit price would be a certain sort of, percentage higher than the previous price that they would have otherwise paid for in-house management. So what is that maximum increase in per unit price that the hospital should be willing to accept? Now, that's an important question, because it should not be unlimited number. That has to have some meaning behind it. So we try to understand that by capturing a certain, certain fraction or certain sort of factor. So this is that factor, a complex sort of equation, but essentially the hospital should negotiate a price increase that does not exceed this factor multiplied by whatever the cost they would have otherwise incurred if they had managed it in-house. So it'll be higher, but it should be higher by this factor. That's what this equation tells us, right? So that's something which we derive. Now, from the vendor's perspective, prior to consignment, the vendor has a certain revenue because they're getting a certain cost price that they are getting from the hospital. And depending on the demand of the supply of the product, they get a certain revenue here. And now that item which was being managed in-house by hospital is going to be moved to consignment. So when that happens, the vendor now has a new revenue, which is the earlier mu multiplied by a new cost that they will charge, which is a factor multiplied by that previous price, right? So they also have a certain factor in their mind, which works for them, which might be different from what hospital thinks is right for them. And then you have the cost of capital, which now the vendor has to manage. So they will have that reduced because the revenue will take away that much of cost that they will be incurring because they are managing the cost of capital and the penalty cost if ever happens. So that is also going to be taken out from their revenue. So for the vendor, they would be trying to optimize this. They would be trying to make sure that their revenue is high when all these different costs are considered and what the hospital is going to pay. Now, based on this, we come up with another factor. Now, this is for the vendor. Like we found one factor for the hospital and we determine what should be the price the hospital should be willing to pay based on that factor. Similarly, for the vendor also, there is a certain factor that they would want to add up on the previous price. And that when multiplied with the actual original price ends up having a new price, which is NV multiplied by C. NV is this factor, right? So there's a new price now. So we can see already that there is a tension here. There is a NHC, which is what the hospital would want as the higher price, which they are willing to accept for consignment. And there is NVC. As long as NH and NV are equal, that's great. But that would not be the case because they have very different, optimization objectives. One wants to increase their revenue. The other wants to ensure that they are not incurring the same level of cost otherwise they would have. So this is the tension that we have. The hospital should not pay more than that NH multiplied by cost. The vendor should not accept anything less than NV multiplied by cost. So anything that happens in between this region is an acceptable contract, right? Because it will be less than NH. And for vendor's point of view, it will be higher than NV. So this will be the acceptable set of contract that we can accept. Is there a question here? Okay. Now, that's based on a situation where shrinkage cost is not accounted for, because we already know that hospitals don't necessarily track that consignment inventory related shrinkage. So if we were to add that shrinkage cost, which we know already that hospitals don't, but let's assume that hospitals now keep track of it and ensure that that is addressed because that is what is needed. Then there will be a new parameter that the hospital should consider, which is less than NH. So right now they are willing to accept as high a cost based on this factor. But after they account for shrinkage costs, this NH will come back a little bit back. So they would not be willing to accept as high a cost as this factor would provide. So this is the new level at which the hospital would be willing, which we consider as that factor called NH prime. Right? So this is the zone in which anything can happen, right? The contract can happen, and that's where both of them will work towards achieving joint optimization or joint value. So that's where the potential for negotiation can be. And if this gap increases, there is a chance that your contract conditions are not going to be good. So hospital might end up being in a contract which is not helping them reduce cost from consignment, which was the objective. So as this gap increases, there is a tendency of potentially having a contract which is unfavorable. So this now provides us some insights. And now we looked at the data that we have with different items, and we examined what would happen with respect to different shrinkage rates, depending on how much the shrinkage rate goes up, for a certain value that they have as threshold value, and in terms of the consignment's value, how much the consignment can benefit them if suppose they went with consignment. Anything less than 1, if it goes below 1, a curve going below 1 indicates that consignment has become suboptimal. It's not helping. Above 1, it's fine. So we noticed that for one of the items, when we increase the shrinkage rate, they end up being in a certain zone at which, when the shrinkage goes a certain level higher, then they start losing money out of consignment stock based agreement. So there are items like that in their system which will not be helped by consignment stock based agreement. Whereas there are also items where actually it never goes lower than 1 for the total shrinkage rate that we considered. So it actually works out fine. So that this particular intuition of this particular figure is that an item for which we don't go below that 1, we're okay with having consignment. Actually, it helps. And if it goes below 1, it can be detrimental. So we do have items of types like that. That's what's been presented here. Now, that gap, I mean, obviously you want to have this to be as low as possible. You don't want to go too low from whatever the threshold value was. That is what would be desirable for a hospital. So these are some insights that we got by looking at it from general versus physician preference items, because remember that our objective is to determine how general supplies and physician preference supplies should be contracted, given what we found from empirical study and from the analytical study. What we found is that the gap between the NH, which is what the hospitals factor for increased price without considering shrinkage, and NH prime, which is the factor for the increased price when they also consider shrinkage. This gap between the two increases when the demand variability goes up and when the price goes up. Now, we already know that physician preference items are the ones where demand variability is high, price is also high. So this gap actually increases in the case of physician preference items as compared to general items. And therefore, what we found is that for physician preference items, basically, it's very important to understand the consignment's impact on cost. General items typically have lower demand variability, lower unit price, and higher mean demand. So this particular items are not the kind where you're increasing the gap. So by using this higher price, unit price type of contract, there is value for general items. You actually can reduce your overall cost for general supplies based on what we found. But for physician preference items, you're more likely to have an unfavorable condition because of their underlying characteristic, right? So this type of contract may not be the right one for physician preference items. Now, the other type of contract that can happen is higher purchase volume contract. So for this one, what the vendor wants is keep the price the same, but increase the volume that they will be selling to the hospital. Now, this would make sense when you have more than one vendor, right? Because the hospital cannot just increase their purchase volume just to get their supplies. They would do so when they can consolidate across two vendors and give portion of second vendor's quantities to first vendor and ask them to also put that in consignment. That's the kind of arrangement the hospital would want to have. So it would be interesting when we are considering consignment for more expensive supplier, because there is one supplier who would want to have a slightly higher price and also want to increase that total quantity that they are supplying. So because if the price is lower, then it becomes a relatively simple solution from the analytical point of view. So we examine that case of movement from one vendor to the other vendor and considering consignment for a more expensive supplier. What happens in that case? And we again trying to derive threshold values for negotiation, understanding what kind of bandwidth where it can help one type of product versus the other type of product. So once again, we are using some of these equations. We have the total cost, but this time we are interested in the volume-based contract. So we have ordering, transportation cost, inventory holding cost, shortage, penalty cost, and material cost. So this is when hospitals are managing it in-house. And then this is when they are managing it consignment. There are some changes in terms of the cost of capital gone, just like we had earlier. But remember that we have two different products. So one product and the other product, we are taking some of the business from one of the vendor and moving it to the other vendor. Therefore, you have two components here based on two different vendors. So not going into the nitty-gritty of the model itself, but the key idea is that starting with the total cost, we want to know what is that maximum purchase volume that the hospital should be willing to negotiate under consignment. And from the vendor's point of view, likewise, what is that maximum they would want to have so that it's optimal for them. So going through some analysis, we determine a certain factor, just like we did in the case of the other contract, higher price contract. Here also we have a certain factor. This is the maximum purchase volume that the hospital should be willing to negotiate with certain, each of these A's and Y's are long expressions. So you have to basically substitute them there to understand what that overall expression means. But the key idea is that there is a certain maximum that the hospital should be willing to accept. Now, what's the insight from that? So we got that expression, and the question is, what happens with that particular expression? So we have that maximum value that the hospital can accept if they don't consider shrinkage cost as part of their calculation, which is the norm, because they don't necessarily capture it, versus the maximum they should be considering if they also consider shrinkage, which should be ideally the case. That is what would help them. So we want to see the gap between these two purchase volumes. And we find that this gap actually increases as demand variability increases. But now we also find that this gap actually shows a convex behavior when the unit price and demand increases. So in the case of higher price, it was pretty straightforward that demand variability increases, price increases, the gap increases. So physician preference items, it's better to go for higher price contract. General supplies, it's better to not go for that. In general supplies, it's good for higher price contract, but not for physician preference items. In this case, it's slightly more complex because the demand variability increases. In that case, the gap increases. But when the price and demand increases, there is a certain more complex behavior that happens between the gap between these two. It's a convex behavior. So we try to now go into each item that we have, general and physician preference items, to understand where the benefit actually is going to be, depending on this contract, higher purchase volume contract. So on the left-hand side, you have the physician preference items like disposable surgical instrument, angiographic catheter of different types. On the right-hand side, you have the general supplies, multi-event mask, surgical hood, blunt fill needles. These are relatively less expensive. And we observe that in this situation, when we analyze it, the advantage of having a higher purchase volume contract is actually going to be more beneficial in the case of physician preference items. So they can get some benefit here when they move supplies between vendors. In such situations, we observe that it's more critical for the impact to be understood on an average general supplies. It actually impacts more in the case of general supplies when we consider all these different factors involved here. So that's sort of our distinct insight that one contract, higher price-based contract, actually could be beneficial when you're going for consignment-based inventory management for general supplies. Higher purchase volume contract actually can be beneficial if you really want to go for physician preference items to be brought into a consignment-based contract, assuming with the understanding that they still have to track the shrinkage cost, because that would be important for them to start looking at. So these are a few implications from our study. That first of all, unless hospitals are taking into consideration the shrinkage they would not get the benefit from consignment stock. It's very likely that they are really not getting the benefit of consignment stock in many situations, especially physician preference items. The lack of information on the part of hospitals increases the outcome uncertainty, right? Because they don't have information about these inventories. It increases the outcome uncertainty from such contracts. They believe that they're going to reduce cost, but actually it can turn out to be the other way around. And this uncertainty could be also because of the power differentials, because in hospitals, typically physicians and surgeons do have a higher, power structure in terms of their ability to decide what they want as compared to materials management team. And it's changing a lot. A lot of physicians, surgeons are now becoming part of this overall understanding of the way cost structure is, how exactly materials are being used. But there is still power differential, and therefore that could be another factor which could result in the uncertainty going up. And then these physician preference items and general supply items behave somewhat differently. So that factor also needs to be kept in mind. The threshold for price, threshold for volume will behave differently for the contracting mechanisms that we just talked about. So having those understanding of different supplies, type of contract, information asymmetry, outcome uncertainty, these are very important considerations that healthcare organizations should keep an eye on and work towards eliminating some of those uncertainties, some of those asymmetries, understanding what the shrinkage cost is, and determining the right kind of contract. So that's my last slide. And with that, I'm opening up for any questions that you might have.
Maybe I can start with the question, and I think it is a fascinating work how detailed you have gone into procurement aspects. But when you presented these results to the healthcare unit, did they have any reactions, or are they kind of doing what you kind of suggest already?
Yeah. So the fact that they don't capture shrinkage was confirmed. Obviously that is one part of our results, which is the empirical side of things, and the fact that they can have higher costs. They had a feeling, an intuition that they might be incurring higher costs, but they don't have a way to actually know what that cost is. But we tell them quantifiably, this is what the difference is. But the discussion on the contract and changing the contract is a longer term process, right? So they have to go through the process of making their internal audience be ready for it. So that's a process that is ongoing, and they are thinking about, these kinds of structuring the contract, understanding shrinkage cost, and then ensuring that when they go up for the contract discussion, they will bring these kinds of things up with their physician partners, with their vendor partners, and then see how it can work out.
Interesting. Any other thoughts, reflections from the audience here? I think they're just tired.
Looks like that. Yeah, it's a Thursday. It's a long weekend, I guess. I mean, Thursday starts the weekend, I am assuming, for some people. So you start getting a little bit, relaxed.
Yeah, but we have, if you physicians, at least the doctors who practice this, I'm sure it must be valuable for them, but also others who are into procurement services. So I think these are some of the interesting aspects.
And if anybody has any questions later also, feel free to send an email, or if they have a reflection from their own organization, they would like to discuss a little bit more about it, I'll be happy to engage in a discussion and, like to know what happens in India in these contexts, what's the way this is managed in India.
Sure, for sure. No, I think, thank you again, Anand, for this fascinating talk. It was very insightful, both from empirical as well as the analytical side of things, and marrying these two are often difficult, which you all try to accomplish. So it is excellent. So thank you again, and I hope we're able to host in person sometime here very soon as well. So thank you.
Yes.
Thank you all for joining this presentation late evening. So have a wonderful rest of the day. So thank you again.
All right. Bye-bye.
Have a good day.